Welcome back, everyone. We're going to close out the neonatal and newborn series with talking about neonatal distress and neonatal resuscitation. Neonatal resuscitation is a skill that should be practiced regularly. This is a low frequency, high acuity skill. And while we're going to go over some of the briefly go over some of the concepts of neonatal resuscitation here in this lecture, we're going to practice this in lab so that you've got some real experience with ensuring a well-practiced procedure should the event arise that you need to engage in neonatal resuscitation. There are neonatal resuscitation guidelines that are published frequently and revised frequently, just as there are CPR guidelines and ACLS guidelines and PALS guidelines. And so you'll want to make sure that we're up to date with the most recent information as you're practicing this throughout your certification period and cycle, and making sure we're engaging in continuous learning so that we're engaging in the best practice for neonatal resuscitation. For the first 60 seconds post-childbirth, the initial steps are going to be reevaluation and ventilation. We're going to assess respiratory rate and ventilatory status for the patient. And our initial steps are going to be without oxygen, because remember, there are fetal circulation relies on hypoxia and hypercapnia to engage in the first breath and to close the pathways between the ventricles and the atria where maternal and fetal circulation were conjoined. So we're going to withhold oxygen initially, but we may not withhold ventilations necessarily. As far as the algorithm goes, if a newborn's pulse rate is less than 100 beats a minute or the patient is apneic, we're going to begin positive pressure ventilation. So our first initial, and I think probably the best way to do this is look at the algorithm here so you can kind of see. So starting with birth, right, is term gestation. Look at the APGAR scoring. Does the baby have good tone? Is the baby breathing and crying? If so, yes, we're going to exit the algorithm and move on with normal newborn neonatal care. If not, let's say baby is flaccid or just not vigorous or has a low APGAR score, the first thing we're going to do is warm, dry, stimulate, right? Position the airway, clear secretions, warm and dry and stimulate. And this is during the first 60 seconds. If there is persistent apnea or gasping, and the heart rate is below 100 or the heart rate is below 100, then we're going to move to positive pressure ventilation. No chest compressions, no oxygen within the first 60 seconds there if baby is apneic, gasping, or the heart rate is below 100. And you're going to see here that we're targeting heart rate. That's what we're going to watch for. We know that with reduction in oxygen concentration with hypoxia, heart rate goes down. So we're using that heart rate as our metric here. If they're not apneic, gasping, and the heart rate is over 100, but they have some labored breathing or persistent cyanosis, reposition the airway, clear the airway, make sure it's fully suctioned. If there's meconium staining, we need to suction that accordingly with the meconium aspirator, monitor SpO2, and then we can provide supplementary O2 as needed. Heart rate's below 100, we're going to start positive pressure ventilation. After a minute, positive pressure ventilation is the heart rate. We're going to reassess again. Is the heart rate below 100? Check chest movement. Make sure that ventilation, any corrective steps may be needed. Consider intubation or an LMA if needed. If the heart rate is below 60, then we're going to intubate and begin chest compressions and coordinate with positive pressure ventilations at 100%. We're going to redo that until the heart rate is back above 100. And then we're going to move into sort of post-resuscitation care, see if the baby maintains. Heart rate drops below 100, we're going to go back to ventilations. Heart rate goes below 60, we're going to go back to compressions. We'll consider the use of epinephrine as an adjunct to resuscitation, but only after other things have been considered. Is baby hypovolemic? Is baby hypoxic? Have we corrected those underlying issues? And then we can consider the use of IV epinephrine if the heart rate remains below 60. Your compression to ventilation ratio is not your 30-2. It should be it's usually 2 to 3 compressions to one breath, and you should be having 100 events of that process. Compression, ventilate, every 100 events every 60 seconds. Drying and stimulating, so nasal suctioning stimulates breathing, suction the mouth before the nose. Again, this goes back and forth. We try to suction the mouth before the nose because neonates are obligate nose breathers, and so by suctioning the mouth first, we reduce some of the risk of aspiration there. You can rub the soles of the feet as far as stimulation goes as well. Free flow oxygen, if cyanotic or pale, provide oxygen after the first 60 seconds, not in the first 60 seconds. If positive pressure ventilation is not indicated, oxygen can initially be delivered through an oxygen mask or oxygen tubing or blow-by. You may need to consider the use of oral airways, but be aware of things like macroglossia, craniofacial defects, choanal atresia. In all of these, you're going to use an ET tube down a nostril instead of the mouth, with the exception of choanal atresia. Bag valve mask ventilation is indicated if the newborn is apneic, has an adequate respiratory effort, or has a heart rate of less than 100 beats a minute after we've cleared the airway, after we've made sure the tongue isn't obstructing, and after we've tried drying and stimulating. Signs of respiratory distress that may indicate you need to go back to bag valve mask ventilation are things like periodic breathing, where it's intermittent, or intercostal retractions, things like nasal flaring, grunting on expiration, etc. We'll use a flow inflating bag. You can have things like T-piece resuscitators that may be attached to that, or a self-inflating bag with a reservoir. In the prehospital world, you're going to use an appropriate size, a neonate bag valve mask and a neonate sized appropriate mask, with only enough movement, just enough squeeze of the bag to ventilate, to just see chest rise. That's it. Always use the appropriate sized equipment. These patients are going to be subject to barotrauma, and you're going to be excited, concerned, confused. Your adrenaline's going to be moving, so you're going to have a tendency to overinflate the lungs or excessive rate. So take a second, get your thoughts together, and make sure we're only getting enough to see the chest rise. We're going to correct ventilation rate to 40-60 breaths per minute when ventilating. Causes of ineffective bag valve mask ventilation are the same for your other patients, right? Pneumothoraces, equipment malfunction, incorrect head position, inadequate mask to seal. For intubations, one of the indications that we'll have is meconium staining in the fluid. Make sure we're using a meconium aspirator and trying to aspirate as much out of the trachea as we can. For congenital diaphragmatic hernias, prolonged positive pressure ventilation may be needed. And be aware that craniofacial defects can impede the airway and complicate ventilation. And that would be a need for, or an indication for, intubation. Make sure you've got your equipment prepared prior to starting. You may need to decompress the stomach, specifically if you've been you're assessing and identifying gastric distension. It could be due to prolonged bag valve mask ventilation. It could be diaphragmatic hernia or other congenital abnormality. Chest compressions, they're indicated if the pulse rate remains at less than 60 beats per minute after resuscitation efforts. Remember that neonatal resuscitation, unlike BLS or ACLS, isn't time-based, it's scale-based, right? It's if this, then that statement. So if baby is apneic after warm, dry stimulate, then we ventilate. As long as the heart rate is below 100, we maintain positive pressure ventilation. If heart rate comes up above 100, we stop positive pressure ventilation. If heart rate drops below 60, we start compressions. If heart rate goes up above 60, we stop compressions. So it's a sliding scale that's moving up and down based on respiratory rate and more predominantly heart rate. For chest compressions in the newborn or neonate, you're going to use either the thumb encircling technique or the two-finger technique. The thumb encircling technique is preferred. This is because you're going to be coordinating a 1-to-3 ratio of ventilations and compressions. The depth of compression should be 1/3 the anterior posterior diameter of the chest, so 1/3 the chest depth, and don't deliver compressions with artificial ventilations. You're going to coordinate 90 compressions and 30 breaths per minute. So it's 1, 2, 3, ventilate, 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 1, 2, 3, ventilate. That's the pattern that you're going to go. Heart rate comes above 60, you're going to stop compressions and you're going to maintain ventilations until the heart rate comes above 100. Reassess for the presence or absence of pulse after 60 seconds of well-coordinated chest compressions and ventilations. If the heart rate's above 60, stop compressions, continue positive pressure ventilation. If the heart rate goes above 100, gradually slow the rate and decrease positive pressure ventilation. Don't stop assessing, though. You're going to continuously reassess. If the heart rate drops back below 100, you're going to go back to ventilations again. Vascular access, so we can catheterize the umbilical cord. If you're going to do that, you need to clean the cord, attach a syringe and a stopcock to the umbilical vein, and then cut the cord with a scalpel. You can insert a low UV line into the umbilical vein, flush the catheter with normal saline, and tape it into place. For neonatal resuscitation, we really very rarely need IV medications. They're a last resort in the resuscitation phase, and that's because most of the causes, the underlying reversible causes of cardiac arrest in the neonate is related to hypoxia or another underlying congenital. Newborn babies don't have lethal dysrhythmias, so pharmacologic agents and AEDs are just generally not needed. It's usually respiratory driven. So we don't typically need pharmacologic agents. Likewise, if cannulation of the umbilical vein isn't possible, you don't have the appropriate equipment for that, intraosseous infusion is going to be the next preferred. You're going to have a hard time getting a peripheral IV on a neonate or a newborn. If in the event that you do need medications, you are going to follow a weight-based formula. So you're going to need to be able to get a guesstimate on the patient's weight. You can use Broslow tapes or length-based weight measurement systems such as Broslow or others. Apnea is defined as a respiratory pause greater than 20 seconds. This can lead to hypoxemia and subsequent bradycardia. It often follows hypoxia and hypothermia, and the newborn's needs for respiratory support to minimize brain and organ damage there. For apnea, assess and manage, get a careful history and find etiologic risk factors. You need to differentiate between primary and secondary apnea, look at the underlying cause. For primary apnea, it's after a relatively short period of hypoxia. They may have a period of rapid breathing followed by apnea again and bradycardia. Drying and stimulating can cause the resumption of breathing. With secondary apnea, this is when hypoxia continues during primary apnea. The newborn will gasp and go into the secondary phase. This is where positive pressure ventilation by bag valve mask is then going to be necessary. Bradycardia in the neonate or newborn is most frequently caused by hypoxia. And it often responds to effective positive pressure ventilation. This is why we use heart rate to target interventions on that sort of sliding algorithm, if you will. Morbidity and mortality for bradycardia are going to be the underlying cause, and then how quickly it's corrected. So be vigilant in this process. The heart rate's less than 100 beats a minute, positive pressure ventilation. If it's less than 60 beats per minute, less than 60 beats per minute, provide chest compression. If it remains less than 60 beats per minute for an extended period of time, you can consider the use of epinephrine and repeat every 3 to 5 minutes for persistent bradycardia. Sliding scale. Summarize the resuscitation protocol. For the first 60 seconds, we're going to dry, we're going to warm, we're going to stimulate. If the heart rate's less than 100, we're going to use positive pressure ventilation without oxygen. After that first 60 seconds, we can attach oxygen if needed, if the patient persists in a state of hypoxia. If the heart rate drops below 60, we're going to start chest compressions with positive pressure ventilations. 3-to-1 ratio, 3 compressions, 1 ventilation with 120 instances per minute. So two interventions per second. It's push, 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 squeeze, compress, 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 squeeze, compress, 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 squeeze. Repeat that process and reassess every 60 seconds. As the heart rate comes up above 60, move back on your chest compressions. If it moves above 100, move back on your ventilations.